Welcome to another episode of the Movement Revisionist Podcast, where we help you redefine human movement one episode at a time. That's the long spiel I open up with. But I got a very special guest today, Mr., or should I say Dr. Zack Atwood. Zack, how you doing? Why don't you tell the people who you are, what you're doing, what you're about, and then I think we're going to dive into some ACL stuff.
Yeah, well, thank you, Mitch, for having me. I do appreciate this. So a little bit of background about me is I'm a doctor of physical therapy, focusing in on sports-related injuries. I've got some extensive experience working with various populations from the youth athlete all the way up to the professional level. Primarily, my main niche is the lower body, though. So that's where I played soccer growing up, dealt with a lot of injuries growing up. And so my mission is to serve that population. So I specialize with soccer players, lower body injuries, and ACL is definitely a big topic of mine. So.
Oh, yeah, especially for football. Speaking of football, let's do a couple shameless plugs. Where can people find you on various social medias?
Yeah.
You got a website. Plug away.
Yeah.
This is your plug session.
Yeah. So I have my own cash-based physical therapy clinic called Primal Recovery PT and Performance, located in Plymouth, Michigan. And then I also, on my social media platform, you can find me at The Football Doc on Instagram, Facebook.
Great content, by the way.
Thank you. And then, and so just trying to, again, grow that a little bit and just serve the soccer community.
Yeah. Now, I love that you serve a specific, I'm guessing you were a soccer player at one point.
I was, yes.
Yes, and you've probably had injuries yourself, and then obviously you probably loved sports, human performance, that probably led you to what you do today.
Yeah.
So it's cool how seeing another professional, how it kind of goes full circle where you take a passion and then take it to that next level.
Yeah.
But now you're taking it to the next level, not just traditional physical therapy, but really being specific with soccer players, or specifically a lot of ACL rehabilitation. Mm-hmm. You might actually know the numbers off the top of your head. Mm-hmm. Are ACLs becoming more common, especially in a sport like soccer or football?
Yeah.
Got to hit all the crowds.
Yeah. It's I would say yes, and so it's getting worse in the sense that it's the ages that you typically will see it is, a typical 13-year-old to like 20 years old is like your very hot area, and primarily females are at a higher risk. Shows 3 to 5 times higher than males. Mm-hmm. On average, though, there's about 200,000 injuries a year, which is just crazy.
Yeah, that's more than I thought.
And in soccer, it is definitely a hot topic, or a hot, sport for the injury. Really, anything what we consider level 1 sports, so like anything that involves cutting, pivoting, jumping, are really at high risk. So it's not just the soccer players, but your football, basketball, volleyball, anything that's along those lines.
Yeah. That
people are sustaining them.
Because again, this isn't my specialty, but I know some things just from the career I'm in. Non-contact is definitely way more common than contact, right? Do you have specific percentages on that, or is there a ratio?
So I'll be butchering if there, don't quote me on this, but I want to say
if it's super wrong, we'll cut this part. Don't worry.
Yeah. I want to say though it's around, definitely over 75% is non-contact.
I was gonna guess 70.
Yeah,
70,
yeah.
30.
It's definitely, I can't remember the exact number, but it's somewhere along those lines.
Oh, it's ridiculously high. I knew that.
And then that's where it's like, well, why? Why are these happening? And what's fascinating to me is the shift in what ACL rehab is now moving towards. Or I shouldn't say moving towards, but more research is being done in areas such as like neuroscience. And so I want to shout out Dustin Grooms and Meredith Shotput. They are really leading the field in looking into what's actually happening to the brain prior to the injury, as well as when the injury actually happens, looking into what actually changes in your brain. And what they've been finding is after you sustain an ACL injury, you lose that mechanoreception, those signals going up to your brain telling you where your joint is in space. And they're seeing that it actually in your brain changes to upregulate your visual input. So we're starting to rely a lot more on vision which then decreases our, ability to sense where we are.
Interesting.
And the problem is when this happens and you never, or if you consistently give that visual feedback throughout the whole process and you're never challenging somebody through, disturbed vision or dual tasking to where you're putting a lot of a cognitive component on it, there's actually plastic changes that happen in the brain afterwards, which then persist for longer. So that's where it's like,
you're blowing my mind right now, by the way.
and it's one of those things that like
because it makes sense, but
yeah.
I just never even considered that.
Yeah, and so we thought like it's all about physical, right? Like get them stronger, but it's like then it's like they started talking about this stuff and showing the evidence, and it's just like there's more to this. And you think about a sport event, right? Like I always use the analogy of like a quarterback, think about how much they're processing through a game, right? There's probably like over 200 inputs that they have to take in and react to. And so it's like if you're just, having them sit in a corner and just, do simple stuff and never challenge them to where they have to think about, dual tasking or disturb their vision, it's like, you're never getting them prepared for what they're going back to.
Yeah.
So it's like, and I'm not saying that it's not all physical, like you have to get them physically ready, where I feel like as my profession specifically, that's where I feel like there's a big disconnect. And some of that's because of insurance, right? Like if you have an insurance plan that cuts you off after 3 months, well, traditional rehab is minimum 9 months. So it's like, what are you doing that last 6? Some are fortunate to where, they already have something in place. They're going to a strength and conditioning facility. They're seeing their PT maybe on the side, or maybe they are seeing cash PT where you don't really necessarily have that barrier. But that's where it's like we're talking about re-injury rates being 25-30%. That's terrifying. Like
is that within the first year?
Within the first 2 years after surgery,
Wow,
you're at risk of injury of your your same side or your other side.
Oh, so it doesn't even
which is
matter.
a whole nother topic, because that's, if you decondition your leg the whole time throughout rehab, well, now you're putting your other side at a high risk. But, there's a lot of factors that go into it. It's not just that. But that's where it's like, it's disheartening, because knowing that a quarter of the people that I work with have a chance of re-injury. But that's where it's like I took that next step of offering services just beyond, the traditional route, and being able to see them for the time until they actually meet those milestones for when they are ready. It's about criteria for me. It's not about time.
Yeah.
So I tell everybody, like, throw
or the
that
insurance
time.
Insurance
restrictions, but just like people have, you get your protocol. It says X amount of weeks, do this, X amount of months, you're back to this. But it's like that's such a generic thing that we're not making an individual. And so that's where it's like I feel like also a lot of people run into issues is they're so stuck to that protocol that then they're not ready for certain things. And if we're talking about a youth athlete who maybe has zero experience with strength training, that's going to take even longer, because they have no training age, so training age is a big factor as well. And most kids that are 13, 14 don't really have that yet. If you're talking about somebody in their 20s, maybe they're a college person or a professional person, that's different.
That's such a good point, especially from like younger athletes or high school level that tear it, because we're obviously professional sports so mainstream. We high level athlete goes down with an ACL tear, and their expectations are they're out at least a year. Now that's an athlete that's already conditioned. They already have strength, and they have some of the best rehabilitative resources in the world. So if they can make it back within a year's time frame, what are the realistic, with all those resources, what are the realistic expectations that your high school female volleyball player gets back in that same time frame?
Yeah, and I like to always talk about the experience. Like, so for example, the perfect point to bring up with this is everybody compares themselves to Adrian Peterson, who got back in 6 months, right? And then of course had that next year was his he was comeback player of the year, breakout year, right?
Yep.
And the problem is now you have kids coming in expecting that, right? Oh no, he got back in 6 months. I can do that.
And we're talking 2.0.
Yeah, and now great. I'm glad that he didn't have an issue or a re-injury with that.
But that is the minority.
Very small.
Very rare case.
Very rare.
Yeah,
and that's where it's like, when I look at ACL rehab, there's so much, not just rehab in general. It doesn't even have to be specific to ACL. there's so many buckets you have to fill. You have to get your motion back.
Yep.
You have to get your strength back. You have to start working on power, elasticity, speed, change of direction. Like, there's so many things that you have to hit that, to me, like, very rarely are anybody ready at, 9 months. Even 9 months, I would say there's still some lingering deficits that you see. So I'm so big on not pushing that.
Yeah.
But then that brings up the thing is you have to make sure you're actually testing and assessing, like, well, what is it that we're lacking so that we can make that change in our programming to then attack that deficit or fill that bucket that we need? Because that's the problem is there's a survey that came out a few years back that showed that over 56% of clinicians were not even like formally strength testing, meaning using either like an isokinetic machine or a dynamometer or isometric test to where you can actually see what the number is, right? They were just using their hands to resist, and so unfortunately,
which
you
is
just
a good quick baseline, but it's you need objective measures to really see a step-by-step progress.
100%.
Especially recovering from an injury over that amount of time frame, you have to have it more standardized, right?
And you're trying to tease out what it is they're still missing, right? Like, you can't tell much from a hand push because they're probably still going to push you away, especially for the quads, right?
Yep.
But not just that, like, you want to make sure that you're doing other form of tests, like, so jump testing, like, vertical jump testing, seeing, all these differences so that you can actually track those measures. And then, again, it's good for you because it gets you your information. It's good for the patient for progress. They get motivated. But more importantly, if your programming is not great, you can make those changes, but if you're doing the testing on a monthly basis, you can make those changes much quicker opposed to those who are just testing at the 6 and then the 9 month mark. So.
Now, I've never rehabbed someone through a full ACL tear, but like if you have those standardized measures, say, you have some quad strength weakness, because that's what a lot of things are testing for, right? Well, it doesn't say you do specific strengthening exercises for the quad over that month, and the weakness is still there. Then it's like, this isn't a strength issue. Maybe it's more of a mechanoreceptive issue because they're lacking the mobility within those joints, so they don't have that strong neural connection there. I'm sure it allows you to kind of check things along the way instead of just trying to stick to a cookie cutter 9 month program that maybe a lot of big box places out there might be doing.
Yeah, and that's where, so you bring up a really good point, because this is now like hot topic in the ACL community, and it's funny because it's something that's been documented for so long, but now it's like there's just even better research coming out, and it's arthrogenic muscle inhibition, or AMI is the term that's been thrown around, and all that means is just a fancy term for saying that there's literally inhibition of your muscle, which is due to many factors. The main driving factors are pain and swelling. When you have swelling, I always use the analogy of like a disconnected battery. It's like your muscle's not damaged. It's just that the connection between what's in your joint, the mechanoreception to your brain, is what's disconnected. And the signal is just foggy, and that's where swelling plays a role. Now, it's problematic because when you have that issue, it's, again, the motor neuron pool in your knee is lower, and then the neural drive to the muscle is less. And so what that means is you're not going to be able to fire your quad as much.
Right.
And so when we talk about normal strength training, if you're at, like, let's say a 50% capacity of actually being able to fire that many muscle fibers and motor units, well, if you do them just through a normal traditional response without doing any sort of interventions to attack the arthrogenic muscle inhibition, you're going to get about a 50% dose. Well, unfortunately, a 50% dose is just significantly underdosing that muscle and chronically underdosing, and then you're never going to get that really good response. So that's why using interventions to try to target AMI, especially early on in those first 8 weeks, it's critical. First is just get your swelling down. But another thing is, what's really cool to see is there's a really good paper out of with Dave Sherman's group looking at like many different interventions, and one of the like focal joint cooling, so actually icing your knee prior to exercise, has shown improvements in output, neural
Cool.
drive, increased excitability in that motor neuron pool. Same thing with like NMES, like actually getting it to fire your muscle and fire fast twitch fibers, which we typically can't get because we just had surgery, so we're not using them as much.
Yeah.
NMES bypasses that and actually targets that, so it's a way you can really build strength. Things like BFR, blood flow restriction training, whereas after surgery, you get that atrophy. That's another great tool that you can use to maintain the muscle mass while minimizing stress on the joint.
Yeah.
Whereas you're still working, like you can work at like 30% of your max effort, but still get that same stimulus as if you're training at 70 to 80%, which is like awesome.
We might have to, next topic might be BFR training, because I've been doing more and more research on it. I'm like, how did I just, I'm in the industry. How have I not been using this more? And I've been using it more for my own personal workouts too, which has been really fun.
And it's great for many reasons. The one thing I will note though is it doesn't, like, if you can lift heavy, it doesn't surpass that. Like it's great for like that acute, subacute phase.
Yep.
But then once you're like back to like, you know, your heavy lifts,
kind of like your maintenance, right?
Exactly.
Like just getting you, if here's A, here's point B, just getting you there without losing as much muscle mass. But then there's nothing that's going to be better than, well, getting them ready for whatever activity they were doing, because that's where there's going to be power, change of direction, whole multi-factors going into their movement.
Yeah, yeah. And so I think it's a great tool for your first 3 months. And then after, so that's like like the first 8 weeks, I use it as a primary training method.
Nice.
Then once like they're like, you know, doing more intense stuff, I use it at the end as like a burnout session of like, hey, we're going to do some knee extensions. You're just going to pump that baby up and just burn it out. So it's not, now it's like, again, you're shifting the focus of like, it's not our primary driver, but we're going to use it as like extra hypertrophy, just burn the muscle out at the end. But yeah, we could go on for a full.
I was going to say, I like hearing the step-by-step. So if in the first 3 months you're just trying to, well, maintain and still, in the first 3 months, can you even add strength, or are you just making sure you maintain what they had before the injury the best that you can?
Yeah, so great question. I would say, yeah, so the first month to really like the first 6 weeks, I would say the number one thing you need to do is just get the knee quiet. So get the swelling out, get your full motion back, get that quad firing, and really hammer BFR. Then it's like, okay, and this is a whole nother topic, but return to running is a big milestone. Okay. And I would disagree with majority of the protocols that are out there because they say return to run at 12 weeks. Unfortunately, you just put that into perspective.
What does that mean, though?
Right, you know? And it's like, if we just took 8 weeks just to get the knee to calm down, think about the impact that's going through the knee when you're running. So you're telling me from that, for let's say 4 weeks, we're going to really build up everything to where you can just go and run and it's not going to hurt, you're going to look great, and it's like,
well, what's a month prior? So at 2 months, are you walking around somewhat normal? Are you getting axial load through the knee just through walking?
So first month, normalizing your walking is critical. Boom. And that's where people are quick to get off crutches. Like I'm cool with like getting rid of the brace, you know, but like crutches, that's a different one because crutches help bridge the gap. You know, and it's like if you go too quick, you see people stiff legging it, peg legging it, and it just doesn't look good. So I'm big on like wait till it's normal. Don't rush that. But then from there, you are working on, you know, getting some more load through the joint, but again, just trying to minimize how much.
Well, and I'm sure this is kind of what you see on a day-to-day basis. There's not, every patient isn't the same, right? Every patient or client, you kind of have a general time frame of where you'd like them to be, but like if someone's normal walking gait doesn't look normal and it's 12 weeks, you're going to then have them start jogging and sprinting. It's like, what? That doesn't even make sense.
Right.
Yeah.
And that's where like kind of going back to what you mentioned before too is, so and I explained the progression of like if you just had ACL involvement. Now,
true.
Meniscal involvement there's different protocols, and majority of them I would say that I've seen, you're actually non-weight bearing for a little bit, and then you're partial weight bearing, and then you're full weight bearing, locked in a brace and full in extension, usually for 6 weeks. So now, but what's funny is they don't modify the return to running.
Oh, okay.
So you're talking about being locked in a
in.
brace for 6 weeks, with barely really putting much weight through it, and then obviously those last week or two, you're starting to put more weight through it, but then you're going to go 6 weeks later to back to a running progression.
Now,
and
is
that's
that
where
fully braced, like all day, even at night? They're fully braced?
For usually, so usually for the first couple weeks, yes.
Okay.
And then they usually, again, I'm not speaking for every protocol, but some will be no brace. Some will modify that, but a lot of them with meniscal involvement, they do have you locked in extension because they don't want to put that pressure on the meniscus.
Yeah.
But yeah, it's so fascinating to me, just the thought process. But again, a lot of these protocols haven't been updated in a while.
Correct. Well, that's where things are always evolving, and in this field, sports rehab, I mean, new protocols are coming out all the time, but you hold on to like the grandfather protocol for probably too long.
Yeah.
There's so much resources now that I think things hopefully can be expedited.
Yeah.
But just like from someone who doesn't see this and just understands basic human function, if you can't even walk, like I already mentioned, if you can't walk normal, why the heck would you add more stress on top of it?
Right.
Because then you're just overloading that recently reconstructed tissue more because you're not using your normal patterns for efficient movement.
Right.
That energy leak has to go somewhere.
Yeah.
And you might as well just overload a tissue that just tore, right?
Yeah. No, and that's...
Is this what keeps you up at night?
Yeah.
I can see why.
Yeah. Well, my frustration is just like the progression to that, right? Like, and I think that we're so quick to get to that big milestone that it's like they're just not ready. And that's where it's like using criteria and actually objectively measuring that can help you guide that process.
Yeah, did Adrian Peterson ruin ACL rehab for everybody?
I wouldn't say that.
No.
But no, a lot of people do mention that though.
Yes.
Or a lot of people just compare to professional athletes, and that's where it's like we're comparing apples to oranges. This person's getting treatment 3 times a day for 7 days a week.
Yeah.
You're getting
you hope they're back
twice
in 9
a week.
Months.
How
much resources they're investing.
Yeah. So it's a very different. Yeah, when you have access to unlimited resources, it is going to be different.
Yeah, for sure.
But
so you already mentioned the return to run at 12 weeks. You mentioned.
Well, that's when protocols. Are recommended. Yeah.
So how much now from your in-person experience seeing this of the people you see, I know it's always dependent, but what percentage of say like high school athletes who probably don't have as much resources as professional, what percentage of them are actually ready to run at 12 weeks?
I would say less than 5%.
I mean, I thought it was going to be lower than 50, but not 5.
And less than 5, I would say. In my experience, less than 5 easily. Now, and what's funny is in that 5% are people that I've treated who actually had an ACL repair, which is a little bit different, where they actually reconstruct the actual ligament itself, which is a newer procedure that's being done now, which is great because you don't have to take like a donor site from like your extensor, your quad muscle, or tendon, I should say, or the patellar tendon. And they actually respond very fast. Like their rehab is way faster. So there's not enough research to show like what is the true differences right now as far as like timeline from an ACL repair versus a reconstruction. But so that's part of the 5%. The other 95%, I would say, are ready at the 4 to 5 month mark. And that's, again, like I'm big on...
But my insurance only covers 3 months.
I know, right? I know.
Yeah.
And I can't even tell you how many people I've had that have followed the timeline progression, have come and seen me, at that point when their insurance has run out, and they look like they're 1 to 2 months out of surgery. And they were jumping, they were running, they started doing agility, and it's just like it's mind blowing on some of the progressions that are out there.
Well,
and
you're stacking all that on a house of cards, right?
Exactly.
It's gonna I wonder why a majority or not It's not a majority re-tear, right? It's like a good 30%? Or
Yeah.
is it?
Yeah.
Okay.
But the problem is that's re-tear rate.
Okay.
If we're talking about return to play, it's even, worse. Like there was a study that showed that 55% of people who like expected to return, like actually return to the sport, like the competitive level though. So that's where it's like, okay, now we're talking only half are actually injuring themselves and then getting back to that same level, or
Wow.
I'm sorry, even higher level. And that's where that's just not good.
And most of that other 50% probably just abandon the activity altogether.
Exactly.
And then,
Abandon or just completely change sports or just
And
decide,
then-
which is fine. Like you could do leisure activities, but like
Yeah,
it's just like
depends on
as an athlete who's super driven to get back, when they look at that statistic, if they are looking at those statistics, it's quite alarming. Like, and then us as rehab professionals need to be better. Like, and that's where it's like, again, going back to it's obviously multifactorial, but I would say that we're doing a disservice from a physical standpoint of even getting these people ready. You know, and I think that there's a lot more work that needs to be done in actually preparing these individuals for what the demands are of the sport. You know, it's just, yeah, it's alarming.
That's crazy. I mean, obviously I'm aware of return to sport protocols with ACL, but other injuries too. But again, it's just like me seeing someone with, say, generic low back pain. Not everybody gets the same cookie cutter exercises, stretches, or treatments.
Yeah.
So why would that be any different for a major injury like this, especially when it's unfortunately a weight-bearing joint where you really have to make sure things are up to par, especially before getting back to that activity. And that's crazy just hearing 50% of the people just never get to that level again or above that.
Yeah.
Which is wild. That changes your life.
It does.
And some people probably handcuff that for the rest of their life because they didn't get the rehab or the care that they needed at that time to then just get back to normal everyday activities.
Yeah. And part of that 50% could also be just the fact that maybe, yes, it was like a physical thing, like they just didn't feel confident in their knee or their knee just felt off. But I kind of already said it, but like confidence and fear of re-injury is actually another big thing that I actually screen for.
Yeah.
And is another reason why a lot of people don't return to sport is because they are fearful of re-injury. They don't feel confident.
Well,
So
that's a grind. If you re-tear, you gotta start that grind all over again.
Yeah.
I get it.
For sure. And then the biggest thing though is like, again, like if you're actually giving these people these tests frequently, assessing, is their confidence going up as they are progressing through rehab? Okay, if it is, great. I don't expect them to be fully confident at 3 months. Sometimes the people that are, that's where you have to get
like
more concerned.
Yeah. You see the other side.
Yeah. But I've had a lot of people who like have crushed physical tests, and then I give them that test, and they like tested 30% out of 100, and it's like that opens the door of a conversation with them of, tell me what's going on. Or if I don't feel like I'm the person for that, which I'm not, like I can help in some capacity, but like I won't step over, somebody else's toes.
At least get them to that next best place.
But then getting them to say, maybe a sports psychologist where they can talk about these things, work on strategies to overcome this, so that that's not the reason why they're leaving their sport or don't go back.
Yeah.
Because
the mental aspect has to be huge.
It's big.
Especially if I never tore my ACL, but if I was like a soccer player just making a routine play, all of a sudden I'm on the ground, and then now I have this year or so of just trying to get back to normal function, and then it's like, oh my gosh, what if that happens again?
Yeah.
Even if you're like a sophomore or something in high school, it's like, do I want to? Is this whole soccer thing really what I want to do? So there's a whole mental aspect. Now, is there an ACL actual mental screening, or is it more of like a yellow flag?
Yeah, so there's some forms that you can use.
Okay.
So ACL RSI is a big one that I've used. The Tampa scale is another one, but I usually use the ACL RSI. It breaks it into different categories of what is, asking various questions about, their knee, but more importantly,
it's just giving you an idea. There's a factor going on here, right?
Yeah. And like I said, if I only looked at the physical measures on her, she would have been cleared.
Yeah.
But unfortunately, one of my number one criteria for return to play is that test. Are you ready?
Is that something you're checking every month?
Every month.
Okay. Nice.
Yep. Usually starting at like 4 months out, because that's when they're starting to do more. You know, my actual like strength testing, I'll start at like 10 to 12 weeks out.
Yep.
So 3-month mark. But the psychological readiness, I'll do that usually starting at 4 months, but then every single month. Because again, I want to make sure that, okay, as they're physically getting better, is that going up as well?
Yeah,
if it's not, then it's like, okay, we can have that conversation or open the door for a referral for the right professional to work with them.
Shoot, of how many percentage of just people you see still don't hit that mental capacity when they hit the physical capacity? I would imagine that's got to be a high number too.
Yeah, I mean, as far as percentage, I would say, like, in my experience so far, most people I have not really had much of an issue.
Okay, cool.
Just because it seems like they're physically, like, they're just feeling great. But
And you're checking those measures along the way.
Exactly.
Too.
And if I need to refer out early, I will.
Yeah.
To try to.
Yeah, if you're like, oh, there's a big factor here.
I won't wait till 9 months to give that
co-manage
test.
this.
Yeah.
You're like physically fit, or someone else's problem.
Yeah, because that's deceiving to them too. It's like they've gone through this whole 9-month process. They passed all your physical tests, and they don't pass that one, and they're like, well, what do you mean I'm not ready? You know, and so it's like, then it's like, and the return to play is a whole nother continuum, right? Like, I think that it's getting better because it's just so broad, and I think we can't just say like, oh, you're cleared, go play. You have to ease them into it, and I think that that's what I've changed recently a lot of, is how I introduce them back to that sport. So we'll use soccer, for example.
Yep.
If I have an athlete, 7-8 months out, they're looking pretty solid. Okay, I'm going to have them start doing skill work, right? Stuff on the ball by themselves. Then, as we're adding, time goes on, adding in another player. So maybe they're doing some passing, some dribbling drills, maybe doing some 1v1 stuff with somebody, so it's more closed, it's more controlled. And then introducing like a 3v3, and then a 7v7, and then 11v11. I would argue 7v7 is actually more demanding than 11v11, because 11v11, more space, less quickness, whereas 7v7 is quite intense.
Yeah.
But it's that continuum, right? So it's not just, hey, go back to 11v11, go play your game this weekend, you're cleared. It's like, no, like, I think that's been the biggest change, though, from the people I've worked with who have had that low psychological readiness score, is really have them gain confidence in each one of those steps. And it's really helped, because by the time they then get back to that last step, they're like, I feel great. Like,
they're not even thinking
about it, right? And that's
the
where
big thing.
100%.
Yeah.
So I feel like that we need to be clearer on what does return to play mean, and how can we make that specific to that person's sport. You know,
absolutely.
But I'm a big believer in introducing them or getting them in their environment as quickly as possible, so that they, with their team or whatever, support. And
yeah, because it could be isolating, especially happens in the middle of the season. Most likely, you're not with your team, and then everybody's probably like, oh, how's the rehab going? How's the journey? It's like, it sucks. Like, there's no sugarcoating it. It's not fun. You don't wish anyone to have an ACL injury.
I mean, it rips your identity, and that's the biggest
Especially from an athlete.
Talk about high school athletes too.
Yeah.
That's like, they're even more vulnerable, because that's their everything. That is literally their entire life. That's all they know.
Yeah.
I think about myself back at that age, and it was tough. Whenever I got hurt, it's like, sitting out was not fun. Like, not being able to be a part of something was not fun. Not being able to play my sport or, get noticed by college coaches, like, that was hard.
Oh, there's so much, for a lot of kids, there's a lot riding on it too.
For sure.
Yeah.
Which is why I'm trying to do what I'm trying to do. Trying to make a difference, right? It's a journey, but.
Well, that's a great plug. Where this has been a great conversation. We're gonna have to do a part 2.
Yeah,
this is too fun. Maybe we can dive into other things besides ACLs.
Yeah,
but I'm just curious, being in the rehab world, more from non-specific pains, not like acute traumas or tears and post-surgical rehab. So awesome to hear your perspective. How are you? We'll do another shameless plug. If someone's made it this far, they probably like either one of us.
Yeah.
But how are you making that difference? You kind of mentioned to me you're trying to bridge the gap between, hey, we have a 3-month window with most insurances, but that's not even half your recovery time period. So how are you trying to bridge that gap for people to get back to their sport?
Yeah, and I would argue that a lot of people don't even do the first 3 months well. Like, I think that that's such an overlooked.
It depends on where you go, right?
Depends on where you go. And that's where it's like, if you have an ACL injury, if there's one thing that you can take away from this episode, please, please, please do your research on your surgeon, your rehab team. It is so crucial in your recovery. Because I can't tell you how many times I've seen people literally come to me 6 months out and they look like they're 2. I've seen somebody 16 months out who looks like they're at 2. So it's like, don't overlook those first 12 weeks. Like, that sets the foundation for you to do the fun stuff.
Yeah.
So I think that's, like, sometimes, like, to answer your question, bridging the gap, sometimes I actually have to go backwards to go forward, to make sure that these people are actually getting those foundational things.
And that's not an easy conversation to have with someone.
No, and it's you can tell the look on their face when I've strength tested, and they've never been strength tested before.
Oh.
And
they're like, what is this? You're like, wait, what do you mean?
And you've been running already?
Yeah.
Like, but
you're like, how have you not retorn this thing already? Yeah.
But it's just that you look on their face and they have a 50% deficit. And it's like, I know they feel it. You can feel a 50% deficit. Your knee does not feel normal.
Yeah.
But it's like to
but
see
they're like,
the
this is
numbers.
Just a process.
Yes.
Yeah.
Sometimes it's quite alarming. But yeah, to bridge the gap though, that's where your rehab and training, it's not separate. At some point it blends.
Yep.
And your rehab should look like training. That's really what it's about. And it's not that, you do your low level rehab exercises and then you do this like later. It's like, no, like, it needs to be blended. And I think, like, when you look at my programming, especially like at the 12-week month and 10-week mark and beyond, you look at it and you're like, this looks like a strength and conditioning program. Like, what? Like, but that's because, like,
you're ready.
Again, you have to give the people what they're gonna be going towards, and so
if you're already doing some sort of plyometrics and getting ballistic at 12, even 16 weeks, by the time that other 6 months comes before the next season starts, you've already had such a foundation of getting back to those explosive activities. It makes sense to, yes, you want to get there quicker, but you want to get there when you're ready for it. Because you don't want to build on an unstable foundation.
Right.
Because either you're going to re-injure it, injure something else, or you're just going to plateau and then you never play again.
Yeah. And that's why I love working with that critical time of 14 to 20-year-olds, because you can make such an impact, but then really lay a good foundation down. Like, you get, like, a lot of them never have, like I said, like, don't have that training age, and so you're introducing movements to them, and it's a great opportunity for them to learn and for them to truly rehab properly and not just, like, get thrown these cookie cutter low level things, or just not getting any individualized care, and it's frustrating. But
for sure,
again, like, being able to get good at squatting, hinging, your jumping, your plyometric phase is so, like, I'm a big into plyometrics, and, like, mainly because it's very relatable to what you're going to ask the body to do with sports, and
absolutely.
so being good at hopping and doing bounds and jumps and all this stuff, you need to be able to be good at that.
You got to load that tissue too.
Yeah, for sure. And so it's like I said, though, there's so many buckets you need to fill throughout the process, and then at the end you need to obviously make it very specific to what, not like do sports specific exercises, but make sure that you're preparing the tissue for what the sport's going to ask. I'm not having somebody play soccer while they're doing a squat or something. Like, it's not something goofy like that, but it's like, you're preparing their body for what the sport demands. Now, what I will also say, though, is from a cardiovascular standpoint, you take somebody who was a soccer player, very conditioned, if you're not doing any form of cardio to keep that up throughout the process, their whole bodies can be deconditioned. And then once you can't wait till they can start running. So like even when they're non-weight bearing, getting creative. Like I have somebody on the assault bike just doing the arms,
pumping it.
you know, doing the battle ropes, doing the ski erg. You know, they're in their brace. You know, it's like, but being able to get creative while you can still get the heart rate up is crucial.
Yeah. You can almost spin zone it for a young athlete and be like, your legs aren't going to be strong for a little bit, but your buys are going to be massive.
Yeah. Oh, yeah, your upper body is going to be killer.
Yeah, exactly.
Yeah. I always
stand walking everywhere.
I always tell people, though, it's like you have one injured out of 4, right? Like, that doesn't mean that we neglect the other 4, or excuse me, other 3.
Yeah.
I train the heck out of upper body starting in your first 2 weeks.
Yeah, it makes sense. I didn't even think about the conditioning aspect.
Yeah. I mean,
so then if you're deconditioned, you're only going to rely on your passive structures even more as you get fatigued. Hence, could also lead to re-injury rate, right?
Yeah, and like
there's a lot of layers to this onion.
Dude, there's a lot of layers, and like athletes don't want to be not feeling athletic, so giving them a really hard your upper body's fine. Give them a hard training, you know, like with their upper body, or strengthen the heck out of their uninvolved side. You know, that's a big thing too, is like there's a crossover effect that you will, when you strengthen your one side, your uninvolved side, there is a carryover effect to mitigate the amount of atrophy and strength loss that you get on your involved side.
Yeah, there's a neural connection.
There's a neural connection, man.
Yeah.
And that's where it's like, just try, again, like be creative. Don't forget the other 3. Don't forget you have a heart too, you have lungs too that need to be trained, especially if you are an endurance-focused sport.
Yeah, absolutely.
You know, but just finding ways to make them feel athletic even in those beginning phases is crucial.
Super important. That's got to be big for the mental game too.
Big time.
Yeah.
Big time.
Dang, dude, this was a great conversation. We could probably keep going, but both of us have lives we probably got to get to. One more time, shamelessly plug, where can people find you, all your great Instagram content?
Yeah.
What is your handle?
So my handle is thefootballdoc on Instagram. I also have my brick and mortar business, Primal Recovery PT and Performance, and then I'm also I have the ACL Institute is a page I have as well, and also a future podcast, I should say.
Yeah, future podcast. Plug that now. Plant that seed.
Yeah.
Awesome. And then if this was such a good conversation, definitely want to have you back on. So if anyone's still listening at this point, reach out to either one of us. What topics do you want to hear next? We could dive into other common lower extremity injuries that people have to come back from. There's so many different avenues we can go.
For sure.
Zach, it was great having you. Any final words you want to give to the tens of people probably listening right now?
No, I would just say, like, if you ever have questions, just, you know, obviously DM me or shoot me an email. I'm always willing to answer any questions or, you know, give you guys anything you want. So.
Yeah, we're in one of those professions, especially with your specialization in ACL recovery, where you don't want to meet new people with these problems, but at least you're a go-to resource for someone who's in that low point. So
for sure.
Hopefully, if you're listening to this, you don't have an ACL issue going on, but if you do, and you're in the Detroit, Plymouth, Canton, Northville, what else is around here area, give Zach a shout out, and we will pick up from there. I don't know.
Awesome. Well,
I just don't know how to outro these things.
Yeah.
I'm still learning.
That's okay.
All right.
I appreciate that.
Yeah. Cut.